Hello friends. Clinical examination in cerebral palsy is always difficult and it's cumbersome to do in a busy clinic. So in this short video, I'll be demonstrating my quick examination in my day-to-day OPD, which I finish within 3 to 4 minutes, and I get rough idea about the condition and I can provide advice on a running basis. I assume that most of the terms are aware to the listeners and viewers, and a detailed video about examinations, interpretations, and the management of cerebral palsy will be followed in upcoming videos. Here, I'm just giving a quick go through examination in a busy clinic. Thank you.
Now we'll get a brief history regarding the births, milestones, history of seizures or any medications, etc. Then we focus on the examination, and I'll try to cover all these points and not to miss any of these. First is ambulation, and try to categorize the child in any of the GMFCS classification. And then we'll try to categorize the gait pattern, whether it is hemiplegic gait pattern or the diplegic gait pattern, and try to fit in the one of the classifications given by the Winter and Gaze or Dr. Kerr Graham. After that, we'll try to have an idea about the spasticity in the child. Here I am trying to look at the spasticity at the ankle, then at the knee level, that is the hamstrings, and try to have a modified Tardieu scale for the spasticity. Some people call it R1, R2, and the difference is the spasticity. Here I am looking at the popliteal angle, and mind you, it is the angle from the vertical, not from the horizontal. Similar examination is repeated and on the opposite side. This gives a fair idea about the amount of spasticity and possible treatment of Botox or the spasticity reducing drugs, or maybe surgical releases in case of uh, uh, fixed contractures. Now I am looking at the adductor contractures and the spasticity, and I am trying to have a combined hip abduction angle, and we can see that there is approximately more than 50 degrees of combined hip abduction angle. Then I go ahead with the prone Duncan-Ellis test for the rectus tightness or the spasticity. You can see that the pelvis is lifting from the bed, and a harder bed will give a better idea about this thing. But nevertheless, I can see. I hope you can appreciate that the pelvis is lifting on the flexion of knees, and that is positive Duncan-Ellis test. Now in the prone position, I go ahead with thigh foot angle for torsional profile. Then in the supine position, I can have a fair idea about femoral anteversion as well as the bimalleolar angle or the axis to look for the torsional profile of tibia. Now I try to have an idea about selective motor control in the child, and I can see that he has a, a fair to poor kind of selective motor control. So again, to repeat, these are the points to cover in the examination, and in a quickly uh, examination can get an idea about the disease and pathology and the condition, and we can quickly guide the parents regarding the uh, prognosis and treatment and other modalities possible at this stage. Thank you.